think we can kick it off. It's early morning. Hopefully more people will show up as we progress in resolving the deep venous conundrum. We're going to start with a live case, and please keep it interactive. We want all of you to keep asking our experts. Human Jalai will start with a case, live in a box, and then we will proceed to the industry symposium by BD. Human, let's see what you have for us.
So I hope more people will come. So extensive chronic venous obstruction is my case, a bilateral chronic venous obstruction plus involvement of the cava. This is my disclosure. And Olivier, please stop me, Makis, if you have some questions and you want to make it interactive. Present illness of the patient is...
the slides are not showing.
Oh, yes.
Can we have the slides?
Sorry. Could we have the slides on screen? I can see my slides here, but not there.
Okay,
Thank
there
you.
you are.
It's my disclosure. So present illness of the patient, 53-year-old male, severe venous claudication. Severe means severe. Patient was feeling really impaired in his daily life. Hyperpigmentation, swelling, abdominal collaterals, pruritus, and as I told you, very important in venous decision-making, impairment in patient's daily life. Past medical history, I'm not going through everything. You see, it's a multimorbid patient with also DVTs and 2 failed attempts of recanalization somewhere else. And also an open thrombectomy. So it was also a hostile groin one side. This is from our daily outpatient clinic. Please, it's SIP, VCSS, Vilalta. We have it also from here. We transferred it to digital. Look, right side 25, Vilalta, left side 11, and venous claudication already after 50 meters. And if you ask the patient, how about going up the stairs, they start already with bursting pain after 2-3 stairs. That is very important in venous claudication.
You have to dance now.
Wow. Okay. So, diagnostics. Let us go on despite the music. It's a nice song. So, very important is to evaluate the inflow in those patients with duplex, with a linear probe. You can see in this, here you can see exactly that I approached femoral vein and deep femoral vein. You have know with which inflow you are going to deal. What are you going to do? And you see the corresponding CT scan. Normally we prefer MRV.
Nikos, since we have you here, can you tell from the ultrasound if the stent is going to fail or not? Given this, the inflow, both the deep and the femoral vein are impaired. Is there a minimum velocity that you're looking for or something that can be a predictor on whether the inflow is going to be enough?
Which vein is the better vein? I have many other videos of this case. It shows, in my eyes, as you said, there is no evidence. We do not know what is 100% good inflow, what is 100% bad inflow. But the femoral vein was considered, in my eyes, as heavily involved.
Yes.
And the deep femoral vein had the best inflow. And maybe we can say it is less than something 50%. It was really a good inflow from deep femoral vein. We measure the flow, but it is prone to error. We know it. We cannot.
Are you looking for numbers? What do you mean?
Yes.
We measure
numbers.
flow.
We measure it in supine position with the EPIC 7 Philips duplex machine in Aachen. So, and we measure it above the ostium of the deep femoral vein, in the common femoral vein, and we think 200 milliliter per minute should be considered as enough. But this is really such a theory without any evidence.
Nico, do you have any comment for this number?
If it's 200, I think it's plenty of volume flow. You know, it'll be 100 less than an actual normal flow. I think it will be good enough to sustain.
Yeah.
You know, just empirically speaking. But
you know, it's really theoretical. It is nothing. So, should we go on? Regarding the classification of the chronic venous obstruction, that is a classification which has been published 3-4 weeks ago in the Journal of Vascular Endovascular Surgery, European Journal. This patient had a type 2 on his left side and a type 4A on his right side, as we discussed the duplex. The classification is based on anatomical extension of the pathology, mainly based on duplex plus MRV or CTV or IVUS later. But normally you need it before you decide, before you make the indication. So the left side had a perfect inflow, the right side had a compromised inflow. The main inflow vein was the deep femoral. That is patients prepping and dripping. You see already hyperpigmentation in both legs. I think C4A or B was bilaterally, always duplex there, and always IVUS there. First angiogram of the right side via GSV, great saphenous vein. Why?
Why?
Marquis, why?
So did you try the femoral vein, or you didn't even try?
Yes, of course. So the femoral vein is the main axis in those cases. Supine position, you saw we can elevate the leg, we can take also smaller saphenous vein, popliteal vein, but normally we go in the mid-thigh somewhere where the artery is maybe a little bit lateral where the vein is lateral to the vein or medial to the vein, and we puncture with a long needle. I think we tried 20 minutes, and it was not very good, and it was a very highly involved femoral vein, and patient was very big. You saw it. It was difficult. In order to save time, we got an access from GSV, and this is now the case.
For our audience, they need to understand that accessing the great saphenous vein is easy to do, but you have a problem now.
You will see it.
Yeah.
Have a problem.
What the problem is, because the GSV goes in the middle of the common femoral vein, and the very important part is the distal part where the deep femoral vein comes in. So, and you see GSV was the access side, and what you see on the left side, we were already through after 10 minutes. So we work simultaneously on right and left side. The left side was already recanalized. So next step. You see, we were struggling with the right side recanalization. And on the right side, you see we have a jugular access already. We have antegrade access from the right leg. And we are through from the left side. And very important, please, in such cases, always go 2-3 times during recanalization to the lateral view or oblique view. Why, Marquis?
Well,
Why do we need
the risk, and I'm nervous even for the wire, looking at the middle of the vertebral bodies.
Exactly.
You're always nervous you may be in one of the lumbar veins.
Yes. If
in
you
the
check,
spinal canal.
if you check the antegrade from the right side, if we would go on, maybe we go in a collateral in a spinal vein, and there is a case report from University of Tehran. They recanalized everything. They are very good. They have more than 1,000 recanalizations. They did it, and while they were recanalizing, they got into a spinal vein collateral. Because of high anticoagulation, patient developed a hematoma and suffered from permanent paraplegia.
There is also, if I can add, there is also a case report during a surgical thrombectomy, and they stented into the spine.
Yes.
My friend Jose Almeida in Miami did not do the oblique view, and he stented exactly the ascending lumbar vein, and the patient was in a big pain after.
So in such cases, in an AP, you might think you are in cava, and then you go to the lateral view. The proof is if you are ventral to the vertebral body and not dorsal. So we proved it, and after several failed attempts with other catheters, we took Triforce. It helps. It's the first step, like a support catheter. And we could get from the right side, as you can see, into the contralateral leg, but we couldn't get into the IVC. Believe me, we tried 1 hour from above, and this from antegrade and retrograde. It was not possible. But that was not bad. With this technique, you at least can get into the already recanalized contralateral side, and then we assured we are in the venous system and not in a collateral. With that, have a look here. So as we knew that we are in the deep venous system, we went back a little bit, and of course this is a shortened video, and then we could get access into the IVC. So, and that was also easier to make a little bit aggressive recanalization.
Or you could snare it if you had to.
Or you can snare it, yes. But that was really easy to see, to prove we are in the contralateral deep venous system. And then, as always, you have to pre-dilate everything with a high-pressure balloon. We took the Atlas Gold, 14 for the femoral area and 16 in the common iliac area, as you can see here. Any comments on this?
Why 40 millimeter long balloon and not 60?
We have 60 and 40 for the femoral area. You can take also 60. In the curvature of the iliac, if you check it from the lateral side, sometimes I don't like the 6 centimeter because it's too long and it straightens your stent, you know, if you stand after stenting. So I like the 4 centimeter, but it doesn't mean 4 centimeter long balloon is the correct one and 6 centimeter is the wrong one. At least you need a high pressure balloon. And you have to pre-dilate everything. So that was, now I come back to Makis, to Professor Avgerino's comment. Why GSV and what is the problem of GSV? That is the problem of GSV. Look at this video. If you get the access from GSV, you cannot stent properly because your stent landing zone will be just below the ligament. But you need the perfect stenting landing zone, especially distal, to secure the perfect inflow, and that is above the ostium of the deep femoral vein. So if you stay with this axis, you have to stent from jugular approach. That was showing you the exact distal landing zone. We did also IVUS. That is very important. Only in combination of a good phlebo and IVUS, you can determine the perfect landing zone. And we, again, assumed there is a good tributary from deep femoral vein, and as you can see, the femoral vein was heavily involved. So then, as always, IVUS for determination of the proximal landing zone. This is, we are not that fast with IVUS. Normally, we do it slower. This is just here also. We took a dedicated venous stent, 20 to 120. In that case, we decided for 1 stent in IVC, and then with a skip technique, you can do it also in double barrel with 214 dedicated venous stents. We can discuss about it. So that is the reconstruction of the confluence. Forget the apposition and fenestration. This is old-fashioned with wall stent. You can do double barrel, confluence technique, skip stent technique on the right side, and we took the skip stent technique in this case.
So the area that, the gap that you're leaving, are there any concerns that you
No.
may get restenosis?
No, we are not leaving a gap of 5 centimeters between the cava stent and 2 dedicated iliac stent. We leave something like 5 millimeters, 1 centimeter, 4 millimeters. And believe me, this is an anatomical pathology. It's a scar tissue. It's like a tunnel. You go, you recanalize the tunnel, and then you have to fix it with some pillars. You do not need pillars all 10 centimeters. You might need it all 1 meter. So that is exactly here. If you recanalize, you pre-dilate, and you stent, and there is just a 1 centimeter skip, it doesn't fall down. So that is the technique. Then we use 2 dedicated stents. In a skip technique, you see we left maybe 5 millimeters post-dilation. Now, what should we do for the distal landing zone on the right side? That is an extensive disease. Olivier.
We need to stand down to the deep vein, not in just at the ostium or into the deep vein.
There are
mostly at
maybe
at the
3 techniques we can reconstruct the distal landing zone right side. Left side was easy. The pathology was in the middle of iliac tract. We stented the pathology and everything is okay. Right side is problematic. We can do hybrid. That means stenting plus endophlebectomy to remove all the post-thrombotic changes and free the inflow from the deep femoral vein. We can do it with a stenting into the deep femoral vein, but then we kill all inflow available from the femoral vein. There is some erythrocytes coming from the femoral vein. Or we can go lateral just above the ostium of the deep femoral vein, which Olivier Hartung is explaining. And I decided also for this technique. So from above, you can see again, we assured exactly with IVUS and phlebo where the landing zone is. We make a mark on the monitor. We dilated it again, and then we lengthen the stent. You can see the stent was deployed from the jugular approach. Normally, we would use it from antegrade, but the access was from jugular approach. You can see exact distal landing zone above the ostium of the main tributary of the deep femoral vein, with a small overlapping zone above the ligament. Do you agree with this?
Yes, I was just looking at this, and which length of overlapping you need?
For me, optimal would be 2 centimeters, but sometimes you have 1, sometimes you have 3. You shouldn't go for 5, 6 centimeters. Why? Marcus, maybe you can comment on it.
I mean, if you do extensive overlapping, you're losing the flexibility of your system. You're creating a very rigid system. Yes. And particularly if you're down there at the inguinal region, you can get into trouble with a fracture in the long term if you have an extensive overlapping zone.
So we say high radial force, good flexibility, good porosity are the adjectives of the new dedicated venous stents. If we go for 5 centimeter overlap, you kill the flexibility of your stent and you create a high material burden of the stent, which is not good for the endothelialization.
But if you got a too short overlap, there is a risk of angulation between the two stents.
So 2 centimeters would be perfect, 3 is also okay, 1 is also okay. So then the stent was deployed, completion angiogram with the tip of the catheter in the deep femoral. You might see some collaterals and say, oh, this is not good, but the catheter tip was really deep. Of course, some collaterals receive some contrast. And if I put the tip of the catheter just distally to the stent, you see the run is good, no collaterals. Left side was anyway perfect because it was easy. And you see the IVC, no collaterals, good run. That doesn't mean that the right side will remain patent. Luckily, in this patient, it remained patent. But in many patients, it goes down.
Woman, some could ask if it's a problem to cover the renal veins.
No, in my eyes, no. You did a study, Jerry O'Sullivan did a study, we published something, and many other centers. Maybe in 1, 2 publications, there is a slight change, but believe me, in our patients and many other centers, there is nearly nothing, no impairment of renal function. And again, the new dedicated venous stents, they are really porous. It's not like wall stent. So you have nearly nothing in front of the renal veins.
It's mainly because in this case, with the IVC occlusion, the renal veins are already draining by the azygos system, and so that's why there is no problem recovering
also
them.
That's correct.
Any questions, remarks? Yes. Why? What was the question? Yes. Believe me, so Blue Flow is a woven stent, like wall stent, or let us say improvement of the wall stent. It is not needed. You can do a woven stent in the ligament because of a high flexibility and because it never crushes, but it is not needed. And believe me, I did Blue Flow, I did hundreds of Abre, 200s of, I do not know, Vinovo, and Optimate stent, sinus venous, and also Bentley stent beyond. I have no fractures, maybe 1 fracture of all stents. And there are also shortcomings of Blue Flow and other
We don't have any data indicating that Blue Flow has fewer fractures compared to the novel dedicated venous stents.
Yes.
You have open cell stents, they're quite flexible, and we haven't seen, I mean, we've seen fractures with all stents, but not such a high rate to be concerned.
And
Place
fracture,
an open cell stent like the Abre or the Venovo or any other stent.
And fracture is today really not a problem. So if a fracture is there, I am not happy. But it is so seldom, it's so rare, and if many of those fractures doesn't affect the flow. So you just reline it maybe with a balloon. Blue Flow is a good stent, but it doesn't mean you have to take Blue Flow.
I'm going to talk about stenting appropriately. So we discussed about clot removal strategies, which patients qualify for an intervention to remove the thrombus, but after you remove the thrombus, it comes placing a stent, yes or no. By the way, we can just have a quick chat. Do you always place a stent after you remove the thrombus?
If it is needed, and I think in my...
This is a diplomatic answer.
Yeah, in my population, 85%.
85%.
85%.
Olivier, you will say 100%.
95.
95%.
Because there are patients that already have a stent.
Do not make things complex. I will agree that in principle, most of the patients need to be stented after you remove thrombus. Yet, we are better understanding now that some patients may not actually need the stent, but if you have any doubt, please place the stent. If you don't, this will rethrombose
Mostly
very
patients
soon.
with a descending DVT.
Yes. The patient with descending
because
DVT
they have underlying disease.
Exactly, compression. Now, when it comes to stenting, everyone thinks it's easy. Particularly the arterial or the aortic surgeons think that venous stenting is something easy. You go in, it's a 10-minute procedure, you place the stent. Well, it's not always like this. The more cases you do, you will realize there are different scenarios when it comes to venous stenting. Multiple collaterals, you don't know where to go through. You may get a thrombosted, you may get IVC aplasia, you may get multiple lumbar sted. It's difficult to identify the vein that needs to be stented or the landing zones. So for those of you who are planning to do a DVT intervention, the key to success is providing good inflow, having good outflow, and creating an adequate conduit. And an adequate conduit is a well-expanded, well-positioned stent. So we just discussed about acute DVT thrombectomy. Why you need to stent after acute DVT thrombectomy? There is an underlying lesion, there is chronic disease that needs to be stented, or there is older subacute thrombus that was not removed, you need to stent it. More than 50% needs to be stented, likely more than 80% needs to be stented. How about chronic venous disease, post-thrombotic syndrome? Balloons do not work. If you're planning on intervening for chronic venous obstruction, you know you have to place a stent. When you're doing thrombectomy, we already discussed about it, you need to remove thrombus by more than 90% to get the successful outcome that you are looking for. And after you remove the thrombus, you need to stent. And when it comes to stenting, we have multiple options available in today's practice, multiple dedicated venous stents, and many times you wonder, which one should I use? The one stent will give you flexibility, the other stent will give you crash resistance or radial force. One size doesn't fit all. But if you're looking for a good balance between flexibility and crash resistance, the Venovo stent works great. It has the unique features of the flared ends that will anchor your stent to prevent migration, because migration has been a significant issue, at least early on, when people didn't have much experience, or even today, they place small stents, they end up migrating. Very easy to deploy. You have the two rolls. We will typically go on the slower version to be more accurate in deployment.
Maybe one thing you talked about accurate stent placement or stent size and small stent. The diameter is one problem, and maybe you can address the length of the stent. Yeah. Especially in nivel cases.
So when we were using the wall stents early on, we didn't have good length, and we had to use multiple stents, ended up in overlapping and risking stenosis. Now, most of the new dedicated venous stents, but particularly the Venovo, has the longest stent available, meaning you can get away with a single stent. So having lengths up to 16 centimeter helps you avoid the overlapping zones and eventually stenosis.
And the migration.
And prevent migration. Actually, I'm going to talk on this on one of my later slides. So stent liberally, stent appropriately, predilate aggressively, use the appropriate size, use IVUS to decide your landing zones, and post-dilate. If you don't extend your stent below the guinal ligament, thinking arterially, you may run into trouble. If you have disease, as Human just showed us, if you have disease below the guinal ligament, do not think twice. Just extend your stent below the guinal ligament. If you have significant disease at the orifice of the common iliac vein, you may have to extend your stent a little deeper into the vena cava. it's okay. Particularly when you have these open cell stents like the Venovo, it's unlikely that you will get a DVT, a contralateral DVT. The concern when we were using the wall stent, jailing the contralateral common iliac vein, the concern was that you will get a contralateral DVT. Up to 10% of the patients will get a contralateral DVT. Of course, extending the stent down, it doesn't mean you're going to jail the profunda. Just stay at the orifice of the profunda. Use long stents, you just talked about it, Human. You want to extend your stent into the external iliac vein. You don't want to have the short stent that may migrate. You don't want to have the short stent that will create an acute angle against the venous wall when the curvature of the vein in the pelvic hollow is. So these are both my cases. This is early on, my experience. I don't do this anymore. Do we do this? Do we have to do this? Ever use such a short stent?
Early on. Now, never, ever. So in my center, for a nivel, for proximal landings on the shortest is 10 centimeters. It's 100 millimeters.
And there's my
Better
other
is
case.
120 because then you are over the curvature, you're in the middle of the external iliac vein, and you have your perfect alignment and secured stent.
Right. It comes down at the external, good deployment. You see the flared ends of the Venovo. This is how you like it.
Mike, is very quickly on this. Sometimes, as you notice, the aortical bifurcation is a bit higher. Therefore, the right common iliac artery compresses 1/3 of the lateral vena cava. What do you do in these cases?
Well, these are the cases that you may have to extend your stent into the vena cava, and it's okay, particularly when you have the novel open cell stents.
And exactly therefore is determination of proximal landing zone with IVUS and with a good phlebogram really mandatory.
And talking about IVUS, this is the study we did in the States, compared patients with or without IVUS. The patients whom we used IVUS had a significantly better patency in the long term because you're not missing lesions. If you use IVUS, you will most likely stent more because you will find more lesions. And that's what we do in contemporary practice. Let's move on to my patient, 43-year-old active female with a venous leg ulcer for more than 3 years. She has a history of right leg DVT and pulmonary embolism. And she has lupus anticoagulant positive. So Olivier, do you have any concerns intervening to a patient who has thrombophilia?
No, it's not a big issue. It's an issue for the length of the postoperative anticoagulation treatment, but not for the indication in my mind.
Probably lifelong I would go if I have
of course,
thrombophilia,
that's what I mean.
right? So this was a patient who was enrolled in the C-TRACT trial. The C-TRACT trial is, I think, still enrolling, comparing anticoagulation against intervention. So this patient was randomized to intervention. So I had, as you, Human, said, sometimes it's difficult to access the femoral vein. So you chose to go through the great saphenous vein. I chose to bring the patient in the prone position and go through the popliteal vein.
Yes, and if you prep and rep the patient really properly with circulated preparation of the leg, you can bend the leg or elevate the leg even it is doable to the popliteal or smaller saphenous vein.
Yeah, I always do the procedure supine when I do the popliteal access. It's not a problem. It takes 2 or 3 cases to get used to it.
I haven't tried it.
And in some cases, I go through the posterior tibial vein. The problem is,
how big of a sheath can you use?
It is a long way, of course.
But you need to abscess later when you do that.
How big of a sheath can you use to the posterior tibial vein?
Oh, I use, at the end, I change to 11F sheet because I have it in my center and I can do everything through it and I take it.
So you can do your IVUS and your stent.
But you point your finger down distally. You can do this for thrombolysis. To use stent stuff, you have to go to the upper posterior tibial vein where the diameter is much larger.
Yeah.
Because some people get confused. You go there, you're gonna rip your vein. You're not gonna.
Because it's easier, probably.
Yeah.
So I have the patient in the prone position. So you're looking on the left side of the patient to not be confused. The femoral vein looks very good, excellent inflow. So when you go higher, now you see multiple collaterals. To cross through that, you need to get multiple plane venography and try to identify the string sign. Okay. So after doing multiple planes, you see, I think I found the string sign. And now I'm trying to cross my stiff glide wire. This is my workhorse going through. And then I use also the Triforce crossing sheath. And this will get me into the vena cava, patent, good vena cava. And now things are much easier. I will do my IVUS, decide my landing zones. I will pre-dilate with the Atlas balloon, 12, 14, 16. Look at the waist of the balloon, how tight these lesions are. And here I am now, ready to place the stents. Starting from top, and I have to get into the vena cava, extending down. And now, let's see. Look at the IVUS. It seems that distal to my stent, there is still some disease. Definitely. And I see the collaterals. And now I'm in a difficult position. Do I stent? I have already messed it up by having my overlapping zone in the inguinal area. And now I will need to place another stent. This is a tough position now.
The way it is, it seems like you have to.
Yes, of course. So you are doing it really nice. So to make the interactive, make the session very interactive, but you have to.
So who wants to stent below that, or who wants to wait and see? Okay, it seems you're half and half.
May I ask you, what do you want to wait and see? That the reconstruction goes down?
I'm on the table now, and I'm thinking, I have already messed it up, having an overlapping zone in the inguinal area.
Come on, it's okay.
And now I have to place another stent, making it 3 stents in the inguinal area and creating a very rigid system. But I mean, I didn't like the IVUS. I didn't like the landing zone. I said, okay, I will place the stent. So here's the third Venovo coming down. At least I enjoyed a very accurate deployment. Look how nice it comes down at the confluence of the deep femoral vein and the femoral vein.
The distal landing zone is now perfect, but the fact that there are 3 stents as an overlap below the ligament is, of course, not good. Because the flexibility is gone or less. There is a high material burden in the, below the ligament, so the endothelialization will be probably affected.
We'll see.
The reason, Mike, is that I told you very quickly, to fix it is because we found, actually you're part of the study, in 200 stents that failed, one common reason is not a good inflow or remaining disease on the inflow. Even if you are appropriately anticoagulated, that's a problem. So I think you should not leave it.
Inflow is the most important part of the intervention. That's what I did. I think we all agree now. So here's my patient 3 months later. Here's my patient 6 months later. And I think we got a very good clinical result.
Very nice.
This is it. We have any question, any concerns, any comments?
On this particular patient, how do you handle the anticoagulation, Mikis?
So with extensive stenting below the inguinal ligament and a history of DVT and lupus anticoagulant, it's lifelong anticoagulation. Now, for the acute period immediately after stenting, low molecular weight heparin 4 to 6 weeks. You want the anti-inflammatory effects, and then continue with warfarin for this patient because of the lupus anticoagulant.
Perfect. Any comments, any remarks? Mike, do we have microphone? Thank you.
Yes, thank you. Thanks for this nice session. I have 2 questions. The first question about the the treatment of acute DVT. I am now confusing about if I treat it as soon as possible, it is symptomatic, or I will wait for medical treatment, because in the ESBS guidelines, if the iliofemoral DVT is symptomatic, you treat it 2A, I think, or 2B. But what is symptomatic? Swelling is a symptom. Pain is symptom.
Good question.
Yes, and most of patients after 24 hours they will get better. No pain, swelling will be.
Well, you're asking them for their symptoms when they're on their bed, and this is the mistake. You have to ask them to walk. And if they walk, you will realize that they get swelling and heaviness.
Yeah.
So it's not enough to just ask the patient, do you have symptoms? Nobody has symptoms when he or she is on the bed. Give them some time to walk around.
Moreover, it's easier to treat the patient at the acute phase and to remove the wall clot than waiting for the post-thrombotic state where you have sequelae and sometimes into the common femoral vein. This is the key of the result, the common femoral vein. If you don't have a good common femoral vein, you will not have a good result by the long term. So if you want to avoid to go for sequelae into the common femoral vein, you need to treat acute.
So,
And excuse me. And the second point about attractive study. Most of you that don't accept the results. I think so. Don't accept the results about attractive study.
We do
Why
accept.
we always speak about attractive study?
You have to accept it because it's a randomized prospective trial, but you have also accept the shortcomings.
Yeah,
One
definitely.
big shortcoming is those centers dilated in 50 to 60% of patients. That means they had underlying disease, but they stented in 25%, 26%. So something is wrong.
But we do accept that the femoropopliteal have a good outcome, and that was a positive study for this. And we don't treat femoropopliteal disease anymore aggressively.
And there was not a clear threshold, anatomical threshold between what is the definition of the femoropopliteal, what is the definition of the iliofemoral.
And most of the
exact line.
And most of the case didn't have the PET scan postoperatively and in the follow-up.
Yes.
This is a big issue.
So, because of time, one last fast question, please, and then we go on. Mike. Sorry. Thank you.
I have just two questions on the diameter of sizing of the stent. I normally use 16 or 18 in common iliac and 14 or 12 in external. Do you think that, and I stent from up to down, but do you think that there is a rationale to put the stent below and after that up to have a better position of the two stents in the overlapping region?
Yeah, the short answer is I've done both. I don't think it matters if you start from top to bottom or go build it up from the bottom to the top. It depends on the lengths that you have. It depends if you want to be very accurate in your distal landing zone, if you want to keep the overlapping a little higher. It doesn't matter. Regarding sizing, most of the patients will be a 16 at the common femoral vein and a 14 at the external, maybe a 12 at the common femoral vein. But typically a 16 and a 14 will do the job. Now, if you have a big patient, you can go 18, but if you keep going with 18, some patients will have a lot of pain. Yeah. Keep that in mind.
It can be chronic thereafter.
And it can be chronic. 16,
not too large.
We used to use 18s when we had the wall stent and didn't have good radial force, and to compensate for that, we used 18 millimeters. But now with the new stents, 16 or 14.
So I think we should go on, and it's my pleasure to ask Professor Lapropoulos from New York, my good friend Nikos, do we really need to treat Turner syndrome? Who and when?
Okay, it's a pleasure to be with you here. I'm going to show you some new data. They've not been published yet. And this is very good because when you want to answer some clinical questions, you have to do proper studies. And now, as we heard earlier, evaluation of venous obstruction may be controversial because symptoms are more pronounced and more often present during studying or walking. Unfortunately, all the studies we do are with a patient in supine position. I mean, how ironic, in 2024, we study the patients in supine position for morphologic information when the symptoms occurs when you stand or walk. I mean, it's fascinating, isn't it? And then, listen to this. We published a paper in 2020 European Journal of Vascular Surgery about, on the treatment and management of iliac vein stenosis. But let's think now. Since iliac vein compression symptoms are predominantly present while standing or moving, the disappearance of stenosis during these states suggests it may not be responsible. Raise the possibility that the stenosis is not true cause of the symptoms and could be an innocent bystander. And this occurred to us because we observe in our practice that many people having stenosis on the iliac vein supine position, the stenosis disappears when you stand. And in fact, there is also a paper from Poland indicating that with IVUS that may be true. This is also a nice paper by Van Buren that shows that if you take 20 normal volunteers, tall, thin Dutch people, And if you look with venography, you can find in 80% of them at least 2 venographic signs that the people have stenosis. You talk about, the haziness, the collaterals are there. But let me remind you, my friends, we have to treat the patient, not the lesion. Unfortunately, 2024 going to 2025, many people around the world, they treat the lesion, not the patient. And this is very sad. Here's a nice paper from Poland. It shows actually IVUS with the patient, entering the IVUS from the jugular vein and looking down at the iliac. And as you see, they found out 2/3 of their patient, right, had stenosis in the supine position, but only 24% during standing. So what are we stenting? Now, also have a paper, actually I was a reviewer for this paper in the Journal of Vascular Surgery by Dr. Black and his group. And then they have stent migration. The stent migration more likely occur in stents with short length, small diameter, or the combination of both. Reasons was the inaccurate vessel measurement, inadequate oversizing, inadequate positioning, and other things to consider, of course, was the stent design, obstruction type, which is basically non thrombotic lesions that allow the migration, location, and length. Now, even if you do IVUS, which is a gold standard of evaluation, we can have some issues with supine position. Right? In supine position, when the patient is hypovolemic, you can have actually a severe stenosis, and when you hydrate the patient, the stenosis goes away. And I've seen multiple times in our group. Now, to solve this problem, we did a prospective study. We got female patients presenting with signs and symptoms related to pelvic vein disorders. We did history and physical examination, and CAP and VSS scores were assessed. Also collect demographic information. We also examined a control with non-signs and symptoms related to pelvic pathology. And you see here, that's a proper prospective study with 100 female patients selected to have more than 50% diameter reduction in supine position. Right? And look what happened. When you put the patient on standing, only 32 have stenosis. That means 68 people have no stenosis on standing. So next time you're going to put a stent for non-thrombotic iliac vein disease, please examine the patient on the standing position, because you'll be nicely surprised like we did. And also we look at the control group, which is 50 females with the same age and sex, right? Still find stenosis in symptomatic people, and even in these people, in 8 of them, the stenosis disappear. Another thing, but how do you provide hemodynamic evidence? So we look at the pattern of flow on the entire iliac vein, and we find that of those people with 50% diameter stenosis or more, 83 of them had reversal of flow in the entire iliac vein ipsilaterally. On standing, only 32 patients had flow reversal. So basically, the hemodynamics show you that even the flow of the entire iliac vein reverses because the stenosis disappears. And this was also evident on the control group. Here is a patient with what we call fixed iliac vein stenosis, and in my opinion, this an appropriate patient to receive stent. This is a female, 61 years old, with swelling and pain for over 15 years. Had a femoropilvial DVD 9 years ago, and was on a coagulation for 6 months with no recurrent events. And you can see clearly on the patient's leg, the heel ulceration and the class 4B changes. And if you look at the ultrasound, it has a peak vein velocity of 3.9. And more importantly, look, the area of the compression, the significant wall thickening and fibrosis with synechia. This type of lesion is not going to expand when you stand the patient, because it's done, because the patient has, spurs and collagen inside the vein. But look at this patient with a position iliac vein stenosis. Female, 28 years old, with flank pain, a frequency for over 10 years, last 6 months getting worse. Symptoms more pronounced on standing, and look, the BMI, which is typical for these patients, young females they are thin, right? But BMI 20 or less. Look at the CAT scan. Anybody say, all right, Nikos, this is a super tight stenosis, no question about it. Well, it is. But let's take the same patient. Supine position on the left, right? 2 millimeters. Standing, the same patient. 9 millimeters. Should we treat this patient? Obviously no, because the patient has no stenosis. Did we say that the people have symptoms and signs when they stand or walk? So the patient's stenosis one is supine, but the standing is no stenosis. So what are we treating? That's why I want you to rethink. That's why we did this prospective study, to give an important answer to a significant clinical question.
Because we are running.
And if you believe this, another patient, very recent, look at this, on the spine position, there's almost no lumen, 2 millimeters, and the patient is, you see here, on the supine position, right? And you can see with the flow, it's a small channel of flow there. But if you stand the patient up, look, a vein of 2 millimeters is 13 millimeters now. It's exactly the same patient. So, please, when you put the patient in bed and you see a stenosis, don't try to sometimes accuse the innocent bystander and put a stent because the patient does not need a stent. I'm not saying all. 1/3 of people with fixed lesions and appropriate symptoms should be treated. This is another patient. This is a patient with fixed lesion because on the standing spine position, there's no change in diameter. There is no any previous thrombosis, nothing, but the patient has significant symptoms. Such a patient definitely should be treated with stenting. Now, how do you select the patients? Well, patients with symptomatic iliac venous stenosis with more than 6% diameter that is fixed, as shown by the video trial. Appropriate symptoms, long-standing edema that extends above the ankle, particularly if it extends above the knee. Pain when all other causes have been excluded. Venous claudication has been reported on non-thrombotic iliac disease, but in my opinion is extremely rare. Venous claudication occurs typically on post-thrombotic iliac vein obstruction. Pelvic symptoms, more likely when collaterals are present and non-varices. But in patients with both obstruction and varices, more careful evaluation is needed, and maybe you do one first and maybe both eventually. For example, if the patient has, ovarian vein reflux and pelvic varices, there's nothing wrong to, put foam on the pelvic varices and coils on the ovarian vein. But wait 3 to 6 months to see if the patient gets better. If the patient is better, do nothing. If the patient doesn't get better, then you can also put a stent in the iliac vein. Now, if you are strong about stenting, you want to put a stent first on the iliac vein, nothing wrong with that. If the patient doesn't get better, you do the coiling and embolization later on the iliac vein, on the ovarian vein. Thank you very much. I don't know if you have any questions.
Thank you, Nikos. Thank you, Nikos. Just a quick comment to your credit. I remember a few years ago, you had a webinar with Tony Gasparis. You had seen a patient with IVUS in the lab, and you said that the patient qualifies for venous stenting. So you brought the patient back for a live webinar case, and at that day, you did IVUS, you did the venography, and there was no stenosis. And you said, we cannot do it.
Exactly.
But you had decided that you were going to do it, but then you said you're not going to do it. So what are the factors?
Well, that particular patient, on the first time, was hypovolemic. The patient, they did the procedure, it was hydrated, and the stenosis disappeared. And I got to be honest, you're going to not treat a normal vein.
So that shows how dynamic this pathology is.
Mike, I agree with you. Yes, but that was our mistake.
Nikos, because of the time, maybe, yes, please, 2 questions.
Oh, my good friend Bart is in there. How are you,
yes.
sir?
Hello, Nikos. Standing a patient up and doing surface ultrasound or doing IVUS is a bit awkward. Yeah. So, what's the role of Valsalva? Is that important to do or not?
Oh, Bart, that's amazing. I didn't have time on my talk, but if you do, for example, venography or IVUS, you can do actually Valsalva live, and this will open the vein up. Right? That's very good. Another thing you can do, you can take a balloon not fully inflated and see if it's catches on the lesion or not. Right? But the thing is, with the I understand starting is difficult, but actually you can put the patient in the sitting position or the lateral decubitus. You have exactly the same result. Because I agree with this. We did for the purpose of the study, it's not so easy to have the patient standing, And if you are to do IVUS, preferably you need to go from the jugular to have a good access to check. Very good points, Bart. Very good.
So you think that
one remark, balloon test is so questionable. So,
Yes.
Valsalva is...
Valsalva, I like Valsalva the
Valsalva
most.
is-
Yes.
Valsalva you think is as good as standing somebody up?
Correct, yes.
Okay.
Is there any other questions?
There are some questions in the back there.
Yes, please.
That's quite interesting information. Just wondering, if we made the investigation, CT scan in prone position, or the intervention as well in prone position, will make things, you think, different?
Fancy you mentioned that because we're writing up the paper right now as a beautiful paper for Cornell with MRI and MRV. And they saw if you change the patient from the supine or the MRI on the prone, the stenosis disappears in most of the people, particularly the people who are hydrated. So changing the supine position increase the distance between the iliac artery and the spine, and therefore you have less stenosis. Prone is another way to do it. It's not as effective as standing or sitting, but still better than supine.
There was another question. Last question.
Thanks for your talk. Patient with I have two questions. If a patient's got pelvic symptoms and good-going ovarian vein reflux, would you treat the ovarian vein first and leave the May-Turner? I've heard that you may make things worse by doing that, but not quite sure about that, because it would seem if you've got reflux, then you've got more blood stagnating in the pelvis. And then the second question is, I've noticed on a couple of cases, if you're advancing the IVUS catheter, the vein can open, and if you withdraw, then it almost shrinks down. It's almost like you're pushing blood through. Have you ever seen that happen, or?
Yes, and I've seen it. It's not so common, and this time, if you do Valsalva, this phenomenon will disappear completely for the second. First question, actually, still a matter of debate, but there are a few clear cases. For example, if the people have also ipsilateral symptoms on the lower extremity, then more likely to treat, the iliac vein stenosis first. Now, if the patient has the both, if you have, pelvic symptoms, I would probably, because I have nothing to lose, use foam for all the pelvic veins and then coil the ovarian vein. But then the problem that happens to most people, they try wait 1 week. The patient, for the pelvic symptoms, you have to wait 3 months and ideally 6 months. If they don't go away in 6 months, then you should stem. Okay, this is what we do. And also, please, I didn't talk about it. One of the biggest problems we have in medicine is miscommunication. There is no such a thing as a May-Turner. Okay? Nothing. We should say topographic anatomy, iliac vein stenosis, iliac vein obstruction, no nutcracker, renal vein stenosis. Okay, anyway.
So for the sake of time, we need to move on. Actually, I will skip my talk on IVC reconstruction. We're going to talk about IVC reconstruction in the Agora session, the session that follows.
Please go to the next presentation.
Nikos, that was a wonderful presentation.
Thank you, sir.
Thank you. We're going to move on with Human Jalaye, how to treat patients with inflow disease. We are skipping this talk. We're going to take it at the venous session at the Agora at 10 for the sake of time, because we are running behind. Okay,
so how to treat patients with inflow disease. Already the first case was an inflow disease on the right side, my disclosure. So now this is focused on the classification which has been published in the European Journal of Vascular Endovascular Surgery. Type 1 is the nivel. Type 2 is a chronic venous obstruction involving the iliac tract. Type 3, additional involvement of the common femoral vein, but you have perfect inflow from the femoral vein, from the deep femoral vein. And then we go to the so-called extensive disease. I would exclude the type 3. Please focus on type 4A, 4B, and 5. You have in 4A involvement of the femoral vein. 4B is vice versa, but very seldom. And type 5, we have 20% of our patients with type 5. So very bad inflow. And this is the publication, and many thanks to 11 other centers additional to Aachen, helping us analyzing 1,207 legs data for this classification. So what are the therapeutic options for patients with inflow disease? Again, type 3 is not a real inflow disease because we have good inflow from femoral vein and deep femoral vein. The distal landing zone of your dedicated venous stents will be above the ostium of the deep femoral vein. You have to detect it very properly with IVUS and phlebo. Now we come to the inflow disease. In a 4A, this is a typical case for hybrid approach for endophlebectomy, if we need or if we are going to do endophlebectomy. Not in type 3. Or you can do it, as we discussed in the first case, in an endovascular technique. You can stent via jugular approach into the deep femoral vein, or you can stent above the ostium of the deep femoral vein, but you have to take care that there is no flap in front of the deep femoral vein left. Group 4B is very seldom, the same techniques you can use, and group 5, you have no inflow. If you do endophlebectomy in group 5, all of those endophlebectomy or recanalized patients will go down. If you treat those patients, you need additional techniques like PTS access trial or something for the femoral vein. Let us focus, because of the time, take type 3 out because it's not a real inflow disease. For type 5 out, we discuss it maybe later somewhere else. These are the real inflow disease you could treat if the indication is there. And we take 4B out because it is only 1 to 2% of the patients. We have 20, 30% for A patients. So what can we do? These are these patients exactly, and this is a real venous map from my outpatient clinic. You see that we are not only drawing something, fancy things, this is a real type for a patient in my outpatient clinic. So the question is the technique. Should we go for hybrid endophlebectomy or should we go for endovascular approach? And if we do endovascular, should we stent into the deep femoral vein or above the ostium of the deep femoral vein? And that is a case you saw today at the first presentation. This is a 4A, and then we recanalized it and stented it above the ostium of the deep femoral vein. With IVUS, it is easy. With IVUS, you can exactly determine your distal landing zone. My next talk is about IVUS. And this is another case, 4A on the right side, and left side was type 3, and you can see how precisely the distal landing zone on the right side has been deployed above the main tributary of the deep femoral vein. So I am making advertisement for endovascular approach. I was the one who did a lot of endophlebectomies from 2009 to 2014, and we published maybe 6 papers about endophlebectomy. I did 2 cases a week, and some on Fridays, and sometimes it was really heavy. Bilateral recanalization plus endophlebectomy took me 4, 5, 6 hours. This is the technique. You open the common femoral vein, you remove it, patchplasty, and maybe AV fistula in a loop shape. Very nice procedure. But the question is, if you need it, this is a part of our studies, and you can see we showed in those studies up to 20, 30% of those patients develop wound healing disorder, lymphoria problems. And in another study, it's a single center study, but we could in one arm 48 patients only with endovascular technique, and in other arm with hybrid approach, and we could show that is the result, the same fair patency rate. Why? Not because of the technique, because of the inflow, because you should do it only in 4A classification patients, so the inflow is diseased. You have a patency rate of around 50%, but in the endovascular arm, patients left the hospital with less complications and much earlier. So it's a clear you shouldn't do endophlebectomy, and please focus on endovascular technique. This is a case to show you when you need endophlebectomy. So a case of 4A. My fellows did the case. They recanalized and called me to come down and check if everything's okay. And this is the phlebo, completion phlebo. It looks good. No collaterals. Run is good. Distal landing zone. I asked them, did you perform IVUS? They said yes. So patient came 2 weeks later. The first follow-up should be 2 weeks post-op. Came 2 weeks later with duplex. I saw thrombosis, and of course we decided for treatment. We used percutaneous mechanical thrombectomy. That is the result, insufficient result. 1 day additional catheter-directed thrombolysis. I think today this is the only indication for catheter-directed thrombolysis in stent thrombosis. Because with lysis you can achieve a really clean reconstruction. And then what was the problem? Should we leave it like this? It will go down again. We did another IVUS, and that was the problem. Please focus on this picture. This is the very distal part of the reconstruction. You see the main tributary of the deep femoral vein. You see the IVUS probe in the reconstruction, and you see a flap in between. What we did, we went on the lateral side, and we ruptured the flap. Have a look, focus on the balloon, how it behaves. And this is the technique you use. You go antegrade. You try, it is just an attempt. You go to the right side, lateral to the post-thrombotic changes, go into the deep femoral vein, and try to recanalize on the lateral side. If it is not possible, take the jugular approach. But how can you say if it worked or not? Do the IVUS again. And here you can see there is no flap anymore. Before dilation and rupturing the flap, after dilation and rupturing the flap. If it doesn't work, you go to the jugular approach and you try come into the main tributary or cross over and then rupture it. And if it doesn't work, this is the only indication for endophlebectomy today. Because if you leave it with a flap, it will go down. If it doesn't work in endovascular technique, open the groin and take it out.
So, Human, we are talking a lot about IVUS, so I think I'm going to hold on your next talk. You're going to skip, so we can have some more time for discussion. So sometimes when it's not always that easy to get the wire behind the flap to prevent occlusion of the profunda. Is there any way we can do kissing balloons inside the deep femoral vein and the femoral vein?
Yes, you know the case
so you may want to elaborate on this.
You can do also from the jugular approach with the 11 sheet. You can go with 2 balloons, 2 8 balloons, one in the femoral vein, one in the deep femoral vein, and dilate them. So with that, you can rupture, you can really assure that you dilated this entrance into the reconstruction. If you put this, and maybe you say he's crazy, why don't you put the stent into the deep femoral vein? First, you have no good stent size. Second, you will kill the inflow from the femoral vein. Even the femoral vein is heavily involved. Those vascular surgeons who open the groin and know how endophlebectomy looks like, even a heavy involved femoral vein gives you some erythrocytes coming up. So if you put the stent into the deep femoral vein, you kill the way from the femoral vein. I think you can do it with the IVUS exactly above the ostium of the vein.
What size balloon in the deep femoral vein?
8.
8?
8. In the main tributary. It depends, of course, to the size of the patient.
Yes, the big issue is that we describe the anatomy with one deep femoral vein, but in most cases, as you know it, there are multiple branches.
Exactly.
That's why it's not very good to go down with the stent into the main branches because we sacrifice the other
deep
one.
femoral vein is always one big tributary which comes from lateral and one which comes from dorsal lateral. So it's not only one. And if you put in one tributary, you kill others. So this is not the best technique and not endophlebectomy. Endophlebectomy only as bailout, as you can see, if you cannot do it in endovascular technique.
Well,
So
I see about endophlebectomy. I see on the floor Mertu Mantepe, who may have a different opinion because I know he does endophlebectomies all the time.
He did.
He did? You want to comment a little bit on endophlebectomies?
So you agree? AV fistula I am not using. I use AV fistula if I do endophlebectomy, and as I do today, maybe 2 endophlebectomies a year. If I do endophlebectomy and it is just one tributary and I think it is not a good inflow, I do AV fistula, but if the tributary is very big, I do not perform AV fistula because AV fistula is one big reason of the wound healing disorder.
The good thing, Human, is that your type 5 classification, we do find it, but it's the minority of the cases. So usually the femoral, or more often the deep femoral vein is open.
Yes,
but when you have
mostly 4A.
But when you have a type 5, how do you get type 5 in your institution? What do you do?
So in type 5, I indicate them for recanalization only in non-healing ulcer. Only a patient had really all issues of conservative treatment, anticoagulation, good compression, weight loss, and still there is a non-healing ulcer. We can do like a critical ischemia, we can do everything. Then I indicate them, but then you need at least a flow from the deep femoral, from the popliteal vein. If the flow from popliteal vein is there, you have to recanalize additionally the femoral vein, and my technique is long duration dilation under aggressive ACT. The ACT is normally, we say, above 200 seconds. In those cases, I go above 300 seconds, and I dilate each segment of femoral vein 3 minutes. So we do not do it normally in veins because we know if you go do a long dilation, you create a DVT on table. So your ACT should be above 300. But many of those cases go down.
Very quickly, do you do phlebectomy in this case or no?
No.
No phlebectomy?
No, endovascular technique.
For type
endovascular
5.
technique, additionally recanalization of the femoral vein.
But would you stent this femoral vein?
No. So if you stent the femoral vein, you create a column with a reflux.
I know, but This is for the
It,
audience.
it goes down anyway.
So how about the PT access protocol? Mert, you want to
Mert.
comment? Since
Microphone? Excuse me, microphone?
So some people advocate that you can open up the femoral vein and the popliteal vein by repeat balloons or by even infusing thrombolytics. Can this offer a durable outcome? Mert, I know you're doing a lot of these.
We use access PTS patients. Only the patients have unhealed venous ulcer after conservative treatment at least 6 months. We truly believe that if we can open this vein nicely and we reduce the luminal obstruction and the ambulatory venous hypertension is reduced around ankle level, and it really helps the ulcer healing. And the patency rate is so far so good, is around 50-60%, but our ulcer healing rate is around 90%. If you
So patency rate 56% at
50.
1 month, at 1 year, at what?
at 1 year.
At 1 year,
It's
56%.
really good.
Nikos, do you see this?
I
you-
doubt that because we did
yeah,
the
if
study
you-
and published. I think 3 months later, most of the people go to the baseline. But surprisingly,
But
most of
ulcer
them heal the
healing.
ulcers.
Yes.
Yeah, that's
This is
Yes,
why
that's what it's all about, ulcer healing. Like for tibial arterial disease.
yes, like
We just do balloons, they go down in 3 months, but the ulcer has healed.
yeah.
Uma, may I ask you a question?
yes.
You always highlight the importance of inflow, but my question is, what is sufficient inflow for venous stenting? Should we consider always
so-
measuring volume flow in the
so-
common femoral vein? Maybe Nikos already answered
No,
this
we
question.
do flow measurement in all of our patients because we want to search what is good, what is not good. Maybe we conduct a research project, but it is prone to error. The same patient today with the same duplex machine in my center has 200 milliliter per minute. Maybe 10 minutes later, 20 minutes later, the same patient is measured 170 or next day 280. So it is prone to error. Therefore, I cannot talk about it. In my center, we think 200 milliliter per minute is the good threshold to say it is a good inflow. But it is just a
In general,
fancy thing.
you have a flow from the femoral artery or vein as an outflow. On average size person, about 300 to 400 ml per minute. If you have 200, I think is enough to sustain, but I don't know what's the critical value. Is 150 enough? I don't know. And then how should we measure? Is
Yeah,
that the
it's
patient
prone to
on
error,
supine
yeah.
position or studying? I think we should do like a big project, many good centers together with honest data, and figure out what's really the good threshold to work on.
Any questions? Please, go on.
Thank you very much for this attractive session. About the type 5, when you want the principles of endovascular treatment of post-thrombotic syndrome in the type 5, any type, you must have a good inflow. In the type 5, you do balloon angioplasty to the distal to get an inflow. Do you also stent the iliac veins?
Yes.
In this case,
In a type 5, yes. In all,
Must.
so you cannot just balloon the iliac tract with this massive post-thrombotic trabeculations and think it remains patent. It will 100% next day, not even next day, next 30 minutes. If you do an angio, you see it's nearly occluded again. So you have to stent the iliofemoral tract, means common femoral vein, iliac tract, as usual. Additionally, you dilate the femoral vein in order to create inflow.
do you think you get a good inflow when you do balloon angioplasty alone in the femoral vein?
Femoral vein, only angioplasty.
But
Do not stent the femoral vein.
do you begin by doing the angioplasty on the femoral vein and look at the results? If the results is good, you stent the iliac.
No,
Or if the results on the femoral vein is not very good, you don't stent the iliac.
To be honest, if I decide to recanalize a type 5 in a non-healing ulcer, I recanalize it. And then, of course, I recanalize everything, also the femoral vein, but I don't say, I think it is not a good result, so I stop the case. No. Then I dilate it with the technique I told you, or
Yes.
PTS access trial, and then
But
I put the stent up to the osteum of the
But
deep
if
femur.
you don't obtain a good inflow by the femoral vein.
But you
Do we
can.
stent?
No, if you cannot, you
Yeah,
have to
that's
stop.
okay.
Of course, of course.
Yeah, right. We
Taking
found
care
like,
not
you know,
to worsen the patient.
I like the torpedo trial, which is like a totally false trial. If you put the stent in the femoral vein, it's a matter of, it's gonna fail 100%,
Yes.
it's gonna occlude.
There is
no
a
way to put a stent on a femoral vein, it's not sustainable.
2018, there is a Chinese work with 114 patients, I think. The half, they recanalized iliofemoral tract, and the half, they dilated the femoral vein in a type 5. And in the other half, they dilated plus stented the femoral vein. All of the 114 patients went down after 6 months. All. Not even one remained.
Kuman, very briefly, you know, I know you mentioned the ulcer, but in our center and the study I'm doing, the biggest problem with the type 5 is venous claudication, not so much the ulcer.
Yes.
What do you do if people have, you know, really bad venous claudication?
Yes. In the type 5, to be honest, I do not do recanalization in type 5 because of venous claudication.
Okay.
Because I know they will go down, and then only the aspect of healing the ulcer is which can drive me to force me to a recanalization. In a 4A, in whom I know the patency rate is above 50%, 60, 70%, I do it for a venous claudication.
First, do not take risk to worsen the patient.
Thank you. So,
Thank you so much, Human. I think we're going to skip your next talk because
Yes, we have no time.
discussed about it. And Olivier, please come up and tell us about your long-term experience, the long-term outcomes of acute DVT intervention.
I have the slides. That's not this one. Not this one. Acute DVT, interventional management, is it durable? No, the next one. Yes, this one. Thank you. So we have been talking about acute DVT treatment. The question is, do we have long-term results for this? So he has made my disclosure. As I already show you this about the treatment of, we can treat this patient by clot removal strategy, but the question is long-term data. We have long-term data for surgical thrombectomy with 10 years follow-up, which are in favor of this clot removal strategy. We have long-term data with CDT. It's not RCT, but it's an observational study that was performed by Niels Backgaard in Denmark, in Copenhagen, and with a 6 years follow-up. But what about PCDT, PMT, mechanical thrombectomy, all these techniques? We have publication on this technique, but all these publications have a follow-up of 24 to 30 months, not one with a longer follow-up. So our goal was to try to find out what are the long-term results. We have been making a retrospective study with Philippe Nicolini from Lyon, and this was our initial experience with single session pharmacomechanical thrombectomy. Median follow-up in this study is 76 months. So from August 2013 to 2017, we include all patients with acute femoral iliac DVT that were included in the database. The inclusion criteria are classical, exclusion criteria with young patient, PE, septic condition, active cancer, and so on. Pregnancy and postpartum were not exclusion criteria. All patients were treated by single session pharmacomechanical thrombectomy. This was the first line interventional treatment of this patient, and before the procedure, all patients were under heparin and under pneumatic intermittent compression. When needed, a stenting was done during the procedure, and all patients have the follow-up at 1, 6, 12 months, and then yearly. So we have to treat 33 consecutive patients.
Olivier, would you want to elaborate, unless you already discussed about it and I missed it, what kind of devices you were using
I will
back
say
then?
it
Okay.
thereafter. 33 patients, mainly women, and you can see according to the lead classification, does it work? Most of the patients were 2 and 3, that means femoral-iliac DVT. Some 6 patients have IVC thrombosis. and 6 patients have concomitant PE. The access were made in all cases echo-guided access, mainly by the popliteal vein, and in some cases by internal jugular vein to use a pulmonary emboli protecting device. Which device were used? So it comes back to 213 to 17. So it's all device, the angiojet, the trellis, and the aspirex. The trellis is not available anymore, and most of the patients were treated with the angiojet. All patients have had the pharmacomechanical thrombectomy using RTPA or urokinase, and a PE protection device was used in 9 cases, 6 times with an IVC filter and 3 times with a balloon occlusion using a Coda balloon.
So the cases that you opted for a filter, what was the reason? Or it was early on
Because
in
they
your
had
experience?
IVC thrombosis or right common iliac vein thrombosis. We don't use filter in patients with left common iliac vein thrombosis because most of them have the May-Turner and the underlying stenosis of the left common iliac vein. But in the IVC and the right iliac, most of the time we use a PE protection device.
So early on in my experience, I was nervous. I was using filters a lot. Then we did a study, compared those who have a filter against those who do not have a filter, even if they had IVC thrombosis. Nothing really happens. And, there will be some clot going into the lung, but it's clinically non-significant.
And moreover, you can have a lot of complications due to the filter.
Exactly.
That's why right now, since I'm not using anymore the filter, I'm using the Coda balloon to protect. And this doesn't let any material at the end of the procedure. This is effective. There is no hemodynamic changes due to IVC occlusion. It works very well. I've got right now a series of 30 patients. I'm going to publish them. So 100% of technical success, stenting 94% of the patients. The ones who had no stenting during procedure were already stented before. So median length of the procedure 110 minutes. No clinical pulmonary embolism, no death, some early complication with 2 thrombosis and 1 major bleeding. Median length of stay was 3 days. No ICU for all these patients. What are the long-term results? This is the big issue. 3 days in patients due to cancer during the follow-up. Reintervention to maintain patency 4 for thrombosis and 3 for restenosis. And we are the long-term follow-up. At 72 months, we've got 76% of primary patency, 86% of assisted primary patency, and 96% of secondary patency at the term of the follow-up. All patients but one had no PTS. The only one who had a PTS at the end of it was a minor PTS. RV delta was 5, and this patient was the one who refused reintervention after rethrombosis at day 1 after the procedure. So this is the only one who had PTS. Median VCSS, VDS, and V delta were 2, 0, and 1 at 76 months. 7 patients had subsequent pregnancies during the follow-up.
Should we be concerned? Maybe you want to share with the audience your experience in stents in childbearing age women.
We know about, by our experience, we have right now we have stented about 1,000 patients in my experience, and the median age of these patients is 38 years old. And most of them, a large quantity of them will have during the follow-up pregnancies. We have right now 80 patients who had pregnancy after venous stenting. We've got a protocol for a patient with which were operated for May-Turner initially without any complication. These patients were treated by low molecular weight heparin after the 5th month to delivery. And the one who had acute DVT or post-thrombotic syndrome for initial indication for stenting, these patients have low molecular weight heparin all the pregnancy long. And we had no rethrombosis or hemorrhagic complications in these patients during pregnancy.
But you're putting them on low molecular weight heparin during pregnancy, prophylaxis.
Acute and post-thrombotic, we treat them all the pregnancy long. And for patients who had primary indication for stenting for an isolated May-Turner, this patient has low molecular weight heparin beginning at the 5th month to 1 month post-delivery. And no complications so far. So we compare this series to an historical series I did with surgical thrombectomy, and we can see patients with single session PMT had a delay before treatment which was higher, a length of stay which was shorter, but there is a difference because with single session PMT we had to stent more the patient. Because we know with surgical thrombectomy we had a perfect clearance of thrombus, and we think that with pharmacochemical thrombectomy, most of the time we are creating a channel into the clot, but not maybe removing all the clots. That's why we had to stent more this patient. The long-term results are comparable within this series. So in all, single-session pharmacochemical thrombectomy is a sure and efficient clot removal strategy for acute DVT without ICU stay, without a short length of stay. And we can say in this short series, it is not a prospective study, this is a short retrospective study, but we have good long-term clinical and patency results and this can avoid PTS, which was the initial goal of this technique. Thank you.
Thank you, Olivier. Human, you have been doing this also for years, you have a long history at venous center. What is your perspective on the long-term outcomes of acute DVT intervention?
So,
10 years. He shared the 10 years experience.
Yes,
not many
I
people
haven't
have 10
analyzed
years,
it all patients, but I can tell you if you patient selection in your first presentation, if it is a real acute descending DVT, you have really good results by respecting the techniques.
All these patients were descending.
But if you have ascending DVT, ascending iliofemoral, also ascending can be iliofemoral, because we are not treating femoral popliteal. If you have ascending, the results are really not good. This is clear. So it depends on how many patients you have in the group of ascending. If it is half of, the results will be damaged.
In this series, all patients were descending DVT.
Yes.
This is
and they have underlying disease. They have normally no thrombophilia or less, but the ascendings, they have hypercoagulable state or thrombophilia.
And moreover, they have inflow compromise.
Yes.
This is the biggest issue within ascending DVT.
Yeah, one thing we have not done yet, but what I check now in our data that is, compatible with the rest of the literature. If you look at your data with ephemeral DVT, at 5 years or longer, the incidence of thrombosis in the ipsilateral or contralateral leg, it varies from 30 to 50%. And another problem there is the second event, Makis, that make you really bad. It's not, if you treat fine the first event, you'll be fine, but if you get the second event, second hit, you might get, worse.
So since you're asking that, do you think a DVT intervention prevents recurrence? Yes or no?
I don't know. Because I have not the data to satisfy this answer.
If there is an underlying disease, a clear underlying disease, and you treat it properly with the stenting, yes.
Yeah, the answer is most likely yes, but you have to prove that,
None of our patients, we had with thrombosis, as you said it, in 4 cases, we treated with good results. But we didn't have any other DVT in other territories in these patients. But there's highly selected patients. No cancer, 3 died from cancer, but we try to treat patients with a good inflow, as descending DVT, no cancer, and so on. So this is a big issue.
We have a question
patient selection
from our audience, please.
It's actually for all of the experts. If you have extensive DVT, extensive symptoms, especially femoropopliteal, fresh DVT because of retroperitoneal fibrosis, so fibrosed iliacal caval, does it change your strategy?
Do you mean femoropopliteal DVT with?
Yes, so really symptomatic DVT, fresh thrombus femoropopliteal, but like fibrosed iliacal.
Acute and chronic.
Yes. Yeah, acute and chronic.
But not chronic because of DVT, but chronic because of fibrosis.
Yes, it's acute and chronic.
Yeah, it's yes, we treat this patient. We treat patients in this group. There were patients who had also IVC hypoplasia that were treated in the same times. So having underlying chronic lesion is not a contraindication to the procedure. It makes the procedure more
Longer.
durable. Not durable, longer. It makes a longer procedure sometimes when you got to treat an IVC agenesis aspect of the agenesia.
But just IVC hyperplasia, it's not like real retroperitoneal fibrosis. It's
Yes,
also other.
The results of stenting, in my experience, for venous stenting for retroperitoneal fibrosis are excellent. We have treated about 15 patients in 30 years with this kind of condition, and our secondary patency rate is 100% at 10 years in this patient. So retroperitoneal fibrosis gave very good results, long-term results of stenting. So this is not a reason to avoid to treat this.
And I think especially those patients who have an underlying disease like this fibrosis, they benefit from treatment because you treat the acute thrombosis plus the real problem.
And do you use different stents? Because they all have like a little bit of, one has a little bit more of radial force, the other one.
For retroperitoneal fibrosis,
Yes.
You will use standard venous stents, nitinol stents. There are different stents. There are some which were retired, for like the Vichy, which was interesting regarding radial force, but we use most of the time the open cells, the nitinol stents. We have a good.
All the venous stents have enough radial force for the retroperitoneal fibrosis.
Most of the time it works well. As we said it already, for post-thrombotic disease, for all chronic disease, we need to predilate. Predilatation is essential while doing stenting. The result you will have will depend of the result of the predilatation you've made. With high pressure balloon, with the high pressure balloon, we go up to 25 atmospheres with the Atlas Gold.
Thank you very much. I think, sake of time, we have to end the nice session. Many thanks to Makis Avgerinos, to Olivier Hartung, and all speakers, Nikos, and many thanks to BD and Inari.
Thank you.
To support this session.